I'm Lisa Pagnucco. I'm an assistant clinical professor at the College of Pharmacy, and I'm the former faculty advisor for the Interprofessional Student Advisory Team, IPSAT, and I'm the faculty advisor for the UNE IHI Open School chapter, which lives within IPSAT. So if you're interested in IHI, it's all what is it, what's the triple aim, and why is it important for you now as a student and in your future? And then how can you enroll in the open school basic certificate courses? This is something that we started on the campus a couple of years ago when we first entered into the Clarion Competition, and we can explain a little bit more about that later. But it helped to give all of our students from all different disciplines and all different levels, whether you're first year, third year on clinicals, an even playing field about the world, about quality improvement and what you're looking for in healthcare. So with that being said, I guess I started thinking about today and thinking, I pretty much don't have to take a show of hands when I read pharmacy, obviously from the School of Pharmacy. I read applications for people who want to become pharmacists. It's probably the same in every one of our health discipline fields on this campus. Many of us joined because of unfortunate circumstances in family members or neighbors' situations where we saw that things weren't working as well as they should be, and we wanted to be part of the solution. So in a way, if you haven't recognized it already, by making that step into wanting to be part of a profession, you are already engaged in quality improvement. So that being said, let's proceed a little bit on here. First of all, how many people in the room have done any of the IHI open school courses? We've got a couple. All right, they are available, and we'll talk a little bit more about that at no charge to students and faculty. So we'll have the students talk about that. And I am going to do a little bit of sort of didactic teaching, get through some of the basics. The goal will be to try and have those slides done by about 12:30. Then I want you to have time to do a little activity where you get to practice your skills, not necessarily from your profession, but just from your own eyes and observation skills on a couple of little vignettes that were used in the Clarion Competition last year to kind of see if Robusto. I think most of you know them, but they're going to help with the presentation as well. All right. So IHI, interestingly enough, is very close by. It's just in Cambridge, Massachusetts. Independent, not-for-profit organization focused on, as I said, quality improvement. They are recognized as innovators and leaders, not only in the US, but internationally. They are sought as expertise. They have been asked to come in and consult, do trainings. They have a different philosophy, and they're sort of cutting edge, and no boundaries get in their way. So their model for improvement involves 3 questions. So no matter what they're looking at, they're asking, what are we trying to accomplish here? How will we know that a change is an improvement? And what changes can we do that will result in improvement? Any of you heard of the PDSA cycle? It's quality improvement talk, but it refers to plan, do, study, and act. They don't spend a lot of time. If there's an idea that's proposed for a change, a possible improvement, they do what they call rapid cycle change initiatives, where they go in, they very quickly do a trial, a pilot, look at it, and they know that it's got to be an iterative process, or a process where you're taking feedback all the time and knowing that your first attempt isn't going to be successful. So they are very involved in getting people's opinion. All right, they have a nice, short, sweet mission and vision, which was longer before this. Just checked it again. Mission, improve health and healthcare worldwide. We want to go for the big stuff. Vision, everybody has the best care and health possible. That pretty much sums up what motivates them. There's a saying that they have on their website they talk about. It's an Irish proverb that says, when you come upon a wall, throw your hat over it and then go get your hat. And they liken that to the idea of barriers or things that get in your way, things that put down your ideas. They know those walls will be there, but they say just keep going. Send something on and you'll catch up with it later. So nothing really is a barrier to them. Their operating values are their core principles, and you can see that first word. It is spelled like that on their website. It's not really a word, but it's called boundarylessness and one team. So the other way to think of it is they function as one team without boundaries. Okay. Systems direct their mission. Obviously, people matter. They are very focused, and they recognize the uniqueness of everybody's background, everybody's vision, and what they see and can contribute. Inclusivity and diversity, obviously, that goes right along with it. Honesty and transparency. Everybody has something to say, and everybody knows everybody's opinion at the table. As well as you see the final celebration and thankfulness. Doing quality improvement work or improvement work generally is tiring, is frustrating, but they take time to celebrate those little steps forward, as we all should do in all of our practices, our studies. I know it's like grueling, but you've got to take those moments to be thankful for what you've accomplished, where you're going, what the big picture is, and they really practice this. Leadership. Any of you heard of Don Berwick? Dr. Don Berwick? Okay, he was the founder of the IHI. He's been the CEO. He also was appointed in the Obama administration to head up the Center for Medicaid, Medicare. He was, I think, considering running for governor of Massachusetts. So he is still one of their founding directors and leaders and senior fellows. Maureen Bisignano is the current president and CEO. All right, so I want to take you back through, many of the students have either heard this from me before. If you haven't, it's important to know where this whole culture of quality improvement came from. And it's going back to 1999, and I know I've said it to many of you before, that seems like the dark ages when the dinosaurs roamed, but I swear in 1999 we were pretty modern, color TV and all. But 1999, for me, I had just come out of residency in 97, and so I was a new practitioner, and we were just starting. It was shocking that this is when we're finally recognizing the significance of errors that go on in healthcare, the very places that people go to for safety and to be able to relax in the care of somebody else. They were starting to realize at that time, and not just realize, but be able to speak about the significance, the numbers of it, the occurrences, the repeat occurrences. It was also a function of the time. I just had this talk in a course on Monday, where in 1999, we were still, many of us, watching our news at 6 o'clock at night, 11 o'clock at night. We weren't picking up our iPhones and watching and doing Twitter and, getting news feeds every split second. So news didn't travel as quickly as it does now. So the fact that we're in this culture right now has actually catapulted this whole change movement, because change and actually quality improvement is driven by what's gone wrong. You can't improve things until you know what needs improving. So to be able to speak about it, you have to have clarity, you have to have the culture that allows it. So culture was going through a change then too. The landmark report from the Institute of Medicine to Err is Human has been quoted so many times. The numbers have been and are now being confirmed that the estimates of patient deaths, anywhere from 44 to 98,000 annually in the US as a result of patient care errors, is way underestimated. Again, this was, 1999. The culture was different. People didn't speak openly about errors, so we knew this was probably underestimated. This report was followed up 2 years later by another landmark Institute of Medicine report called Crossing the Quality Chasm, where those errors were investigated further and really trying to come up with strategies for improvement. Now that we know we have a problem, how can we fix it? And the chasm, the word chasm, was, for many people, articulated as the divide between where we have quality care right now and where we know our care could be. So that quality that was not just a little sliver in the earth, it was a huge gaping hole. So they came up with 6 strategies for improvement, and as you go in your own professions and in your careers, you'll see these terms, they've been adopted widely. 6 aims for improvement are that care should be safe. We hope it's always been safe, but we are, as I said, realizing it wasn't. That care should be effective, that we're basing choices for care on certain things. That would be our evidence-based medicine that we talk about, okay? Patient-centered. As we talk about patient-centered, it means things in different areas that we practice, but it means more than just we're talking about a patient. It's actually bringing the patient in and making them part of the decisions. What do they believe, the cultural beliefs, et cetera. Timely, obviously, that we reduce wait times, that we have availability for care when it's needed. Efficient. One of the things we'll just show you some slides on is our healthcare system is very wasteful. And so efficiency refers to are we duplicating efforts, and we do a fair bit of that. And equitable, you'll hear this when we talk a lot about disparities, whether it's health disparities, we wanted to really minimize the occurrences of that. So here's the Triple Aim Initiative. It was a report put out, and it was a way of thinking that was adopted and published by Drs. Berwick, Nolan, and Dr. Whittington. It was published in Health Affairs in 2008. It was something they wrote in 2007. And the general gist, all of this is really to say that they want all healthcare providers and organizations and leaders to be thinking about pursuing these 3 areas, these dimensions, to improve the patient's experience of care, which is their satisfaction and a number of things. Improve the health of a population. So rather than just individual episodes of a person's care, what is this saying about a particular group of patients? At the same time as reducing per capita costs. Again, I'm going to take you back to that simultaneous pursuit. So we can come up with all sorts of ideas that will improve a patient's experience of care, but they might cost more. That's an easy fix. To try and look at our systems and do these 3 things at the same time is a bit challenging. But it's also where we're at with the Affordable Care Act. Right now, we've been given incredible opportunities to think of new ways of delivering care. Many of the integrated healthcare delivery systems are adopting the IHI's Triple Aim and trying to come at it not just from the executive level, to come at it from the frontline practitioner level, meeting with the finance people, meeting with the state people, as well as looking, how many of you have heard of accountable care orgs? Okay, and not well defined, but this is a great opportunity because they are not well defined. This is a chance for new practitioners to have input, to bring forth what you see with fresh eyes about how we can combine different levels of care, home nursing with community pharmacy, with an acute care hospital, for example, partnerships that never used to exist. That now we're seeing this happen, and people are embracing this because they see ultimately it improves care for the patient. All right, so another way of looking at it again, the triangle, triple aim, you can break it down into individual experience of care. That's from their perspective, satisfaction and quality, health of a population. And again, when I say population in the triple aim, a population is something that's defined by the organization, by the people. So it might be that a particular clinic, for example, says, we really want to focus on our patients with diabetes who've got an A1C over 8.5, and that will be their population. Whereas another organization might say, we want to focus on all of our patients over 65. Very different population, but you're allowed that freedom and your professional discretion to go after the people who need your care and your resources the most, and the per capita cost. Okay, so most of you have probably heard this. If you have not seen the movie Escape Fire, it's available at the library. We've had a couple showings on campus, may happen again. It is a really, really candid look at the state of the healthcare system here in the U.S. Oops, I bumped ahead. But you can see that we pay a lot more per capita than the rest of the developed world. And at that time, it was about $8,000 per person per year compared to $3,000 per person per year. Most of you who know me know I'm from Canada, so I always say, don't worry, Canada's not much better. We pay less, but we still don't have great care, okay? Difference. This is from the OECD, where the data is a little more updated. We're already at the big tall one right here is the US. We're already at 8,500 in 2011 information, 8,500 per capita, compared to about 3,300 on the average in the rest of the developed world. So we're spending a lot of money, and people are starting to look at this seriously for sustainability reasons. Just clearly, we have to be putting our resources elsewhere. So this is a big part of the looking at the Triple Aim. Right now, our spending on healthcare is about 18% of our, I'm jumping ahead, gross domestic product. And you can see by this, it's estimated to be 20% within the next 6 years. So that's probably now in the next 4 years. I wanted to pull this because Maine Quality Counts is one of our quality initiatives or quality improvement organizations in the state, well recognized across the country for the number of initiatives and partnerships it has in quality improvement. And even at their meeting in 2013 in April, their headline was Aligning Maine's Forces to Become the First State to Reach the Triple Aim. Awesome goal. And there are so many people behind the scenes that are working on this. You have, at this point as a student, you may not be aware, but when you get out into practice, reach out and find out what's going on wherever you end up practicing, because all the states are looking at this. Okay, behind the Triple Aim, there's some design principles. Focus on individuals and families. Again, this is who we are all here to serve. So we oftentimes get wrapped up at an executive level and we forget about who really needs our care. The redesign of primary care services, and this was a lot, and the structures involved, because these were ending up supposed to be the places that our patients could go to when they weren't acutely ill, but they were becoming barriers. They couldn't get seen, their wait time was too long, so we've been really looking at that. Population health management, now that we have a lot of information and data, we can actually make predictive models of who needs our help the most, rather than just sort of waiting for somebody to walk in. We can be preventive and go forth. Cost control platform, I've given you a little bit of background there why. And system integration and execution has to do with, again, some of the redesign of the models, how we delivered care, how we pay for care. This is right now an exciting time. It's also a little bit of a scary time because the models aren't worked out. But this is why reaching out to new practitioners who can think differently, who haven't been 20 years in an established institution, you'll be able to maybe come forth and voice your observations and your ideas in an environment that's looking for new ideas. All right, so I'm not going to read through everything. I highlighted a few things under each of these designs, but involving individuals and families. One of the things that comes up often when you look at why we spend so much per capita is that we do have a more is better culture. And I'm sick, I must have an antibiotic when I go to the doctor, things like that. We are one of only 2 countries in the world that has direct-to-consumer advertising for prescription drugs. So, and if you watch those commercials, at the very end, it always says, ask your doctor if you are a good candidate for blah, blah, blah. So patients go in and use that 10, 12-minute office visit, and they want what they saw in commercials. Other countries, this isn't the case. So we do spend a lot more money on things that maybe aren't necessary for patients and maybe putting them at risk for side effects, adverse effects, okay? So that's one of the things. But the employing the shared decision-making, when we talk that patient-centeredness, as I said, it means a lot of different things to different people, but not every patient understands our healthcare system the way we do. So finding out what their level is at, giving them the resources they need to be able to participate in a decision about their own care, respectfully understanding their home situation, et cetera. It's a big part of that. The other part of this wastefulness is when you look at the dollars spent, 75% of the dollars go towards conditions that are preventable. Sorry, a little happy on the advancer. What we need to do is, and I describe it to my APPE students, that it's a bit like being in an ocean freighter. and asking and getting the call from the harbor that you need to come back. A big cruise ship or Royal Caribbean cruise ship cannot turn around like a speedboat can on a dime. That ocean freighter's got to go miles out of its way to get that circle and come back. To be able to reduce our preventive disease, dollars that are spent on diseases that could have been prevented, we need to get back to fixing the primary care system that I mentioned was a barrier. We need to be able to get to people and give vaccinations so that they don't get pneumonia and take 3-4 days in the hospital, lose time away from work, things like that. But it takes a while to fix the system. We can't turn it around quickly, so you're going to be part of the solution when you get out. Okay, so, I jumped the gun there, redesigning primary care services and structures. Again, using teams. This is why you come to the interprofessional things. You want to learn about being with teams. It is real. It really is important that you start to do this because this hasn't been the way we practice. Teams will make the care for patients so much better. I just came from an interprofessional team clinic meeting this morning, my old site, which was always nice. We have social work, have a health educator, we've got nurses, medical assistants, physicians, residents, pharmacy students, and pharmacists. It's wonderful. We all have our input into the patient's care. And the patient has their input too. All right. So the better coordinating care. We have a great system for all sorts of specialty and referrals, but we are very fragmented. And that's another huge area for waste and for people to get lost in another chasm. So better coordinating the care is important. This is where patient-centered medical homes come in. That's just one model of care that's been embraced to try and actually close those gaps, have the primary care provider be that gatekeeper for a patient, help them navigate through. So that's one avenue. Okay, and so the third design principle is improving population health management. I already alluded to being able to deploy your resources to the patients who need them the most, the high-risk individuals. Right now, we have all sorts of, right now I work in the main med system, so we might have things called the CCT, or community care teams, or a care transition coordinator, CTCs. I mean, all sorts of people have been changed. Their jobs have taken them from one avenue into another because they're starting to see who's using the emergency rooms, who's being readmitted every month, and saying, we need to get to the bottom of that rather than just deal with the acute episode. So it's coming. All right, and this is always a good graphic. The 80-20 rule was something in business end. This 80-20 applies for all sorts of things. 20% of the population uses 80% of our healthcare dollars. So doesn't it make sense that we would put a larger percentage of our healthcare resources towards helping those 20% fix what needs to be fixed, improve their quality of life and their medical care, and then be able to get around to the preventive work. And that was the reducing the waste part. Okay, this Escape Fire points this out, and this has been a driver behind a couple of other quality improvement initiatives. Oh, I jumped it again. 20 to 50% of medical scans in the U.S. should not have been done. This is just one example that has been behind the Consumer Reports Health program for Choosing Wisely, actually, which has gotten the support from all sorts of the medical organizations on tests that should not be just done as a matter of routine, to start reducing the cost. Because every time we put a patient into a test, for example, we are putting them at risk. We're taking them away from their job. They have to book an appointment. If the test is not going to be telling us anything of value, or it's been done somewhere else and we just are not a connected system, we've wasted dollars and time, and we've disrespected the patient as well. All right, the last one I talked about was the supporting the system integration and execution. This is, again, a lot more at a higher level about, this one here has the social services, matching capacity and demand. The social services component of new healthcare is huge. We do not have enough coming out to actually support, but it's nice to see that this is being recognized. People many times need a lot more of those skills and support to be able to manage their medical situation. All right, so this is where we are going to transition into an activity, right? Who's coming up? Maggie is going to lead this. What we've done this year is taken last year's Clarion case. It's a fictitious case, so any of you who are here to sort of think about Clarion Competition, great. Those of you who aren't here, just bear with us. This is all part of IHI. But they had put out a couple little videos this year about a fictitious patient and the care for heart failure. So we're going to end up showing you a little bit about that, telling you a little bit about it, and then asking you to work in groups a bit. So Maggie will run through that, and we'll get started.
Do you want to have them all get in groups right now, because there's people on the outside?
Oh, on the outside?
Like, here.
You don't have enough tables.
Okay. All right, everybody take a quick breather. That was a lot of information. But thank you, Dr. Pagnucco. I think we have a great baseline about the goals that we're reaching for in bettering our health system. And I think that she gave some great examples of practical ways that we can enhance the care that our patients are getting. So that's what you guys are going to have to start thinking about right now. So we're going to go through the case that was put out by the University of Minnesota. You can see the authors up there. They wrote this case. They do this every year, and this is what the case competition is based on. So this last year it was called the Heart of the Matter, and we were introduced to a specific disease state, heart failure. So as of 2012, Medicare reduced the amount of reimbursement that they were offering hospitals to a specific amount based on how many readmissions they had. So I hope all of you know what a readmission is, but that's when someone comes into the hospital, gets discharged, and then comes back within a certain amount of time. So they chose 1 month. So if a patient came back within 1 month, they weren't getting the same amount of money as they would have for a new admission, sort of. So we're looking at heart failure specifically, and this fictitious health system is based in Oregon. It's called West Plan. And so West Plan is a broken system. It's looking to sort of come up with innovative ways that they can increase the care that they're giving their patients, not necessarily in the amount of care, but the way that they're caring for their patients. So today we are going to use the 3 principles of the Triple Aim, which you should all be very familiar with now. Don't worry, you're going to get a handout about it too to remind you. And you're basically going to look at each aspect of the Triple Aim and come up with a potential solution to help us reach these goals and better the system. So this is just a little bit about West Plan. It's a nonprofit organization. They have about 1 million ambulatory care clinic visits annually. They have quite a few physicians. And their mission is to improve the health and well-being in partnership with their members, patients, and community. This is a pictorial definition of this health system. So they have each of their different specific clinics, and you can see that they're all interconnected. So when you're thinking about potential solutions, don't forget that you can create something larger than just the single patient that we're going to look at. So here we're just looking at what we're being asked to do. So in our case competition last year, they posed, each team was made up of four people, and we are looking at here a medical director, the head of the disease and case management program, the head of home care and hospice, and then a nurse manager. So the students that did the case competition last year became these directors, sort of, and they were in charge of coming up with specifics related to their area of practice. So we conducted root cause analyses, and we presented our findings to a board of directors, so to speak, that were actually real healthcare professionals in the Portland area. So it's really great that they can see the work that we're doing now as students to prepare ourselves for what's out there and what we can offer people. We might as well practice while we're students. So here we go with Harlan Reeves. He is a sick man. We're going to watch this quick video and be introduced to Harlan and what's going on in his care right now.
Now that we've gone through your labs, let's talk about your medications. Well, it's good that you're already on an ACE inhibitor and statin.
He doesn't take them regularly. I tried to remind him.
It's important that you take those medications as prescribed. Your heart isn't working as it should. So, I think we should also start you on a diuretic.
What's that one for?
It helps get extra fluid out, which can be a problem with CHF.
Do you know how much these new medications will cost?
No, I really don't.
Will our insurance cover it?
Some diuretics are on a generic list. Your pharmacy should know. I believe this one's on that list, but I'm not really sure.
With the insulin he already needs, we just can't afford any more medications. How important is this new drug? Does he have to take it every day?
Hopefully insurance will cover it. All right, so I've got you started on the diuretic, and I've also just requested a referral to a cardiologist. Looks like we've covered everything. Thanks for coming in today, and the medical assistant should be in with your paperwork.
I just don't want to take any more pills. I've got enough already.
But dear, the doctor says you have to.
All right, that was fun. Okay, so how confusing was that, right? This is the patient's first visit, just being diagnosed with this major health problem that really wasn't explained very well. So imagine that this was one of your family members or you personally, and just thinking how you must feel in that situation, and kind of thinking after we watch the second video, you're going to kind of put all this together and think how this visit could have gone differently and what kind of resources you could have offered this patient. So just to review, Harlan Reeves, he's 69, he is married, he has 2 children. His conditions include heart disease and diabetes. He doesn't have a fantastic lifestyle. 12 years of diabetes, he's overweight, he smokes and drinks, eats fast food, he has a sedentary lifestyle. And you can see that 14 months ago, he started having chest pain and breathing problems. So he's diagnosed with stage 3 CHF.
Now, wait a minute. Which office are you calling from? Oh, okay. He's not doing well. His weight has gone up again. We have a new prescription that we just can't afford. We have so many medicines. We really don't know anymore which ones he should be taking and how many, when. You know, he has so many different doctors, and none of them seem to talk to one another.
Hi, Dr. Lorenz,
Yes.
do you have a minute?
Yep, I have just about 3 minutes.
I spoke with Harlan Reeves' wife about rescheduling his appointment. She's concerned that Harlan's weight has gone up and he's not taking his medications. They sound pretty confused about how to handle them all, and it sounds like they're finding the medications too expensive.
Who's that again?
Harlan Reeves?
I don't recall his case. When was the last time we saw him?
About 8 months ago. He was scheduled for an appointment 2 months ago, but remember we had to cancel on him. And we still haven't been able to reschedule.
Let's see, what is he taking? Well, there is what we prescribed, and it looks like he's also taking something for diabetes and acid reflux.
His wife sounded pretty overwhelmed, and she said that all those medications are just too expensive for them and they're having a hard time keeping them straight.
Well, he definitely needs to be on the ones I prescribed. Have him work with one of the cardiology nurse practitioners.
Okay.
And I don't really know anything about these other medications. probably he should work with his primary care physician, okay?
Okay.
You want to pass those out? All right, so we're going to get into teams here. Those of you on the sides, just work with the people around you. And we're handing out a sheet. What? Oh, teams of 3. Yeah.
Okay, the sheet, one sheet per group is going to have 3 different colored Post-it notes on it. And the Post-it notes are in blue, yellow, and pink. And we're going to move this board over here. Whoops, Daisy. Sorry, Maggie. What we would like you to do is, thinking about the videos you just saw, think about things that would improve the care that you saw in the 3 dimensions of the Triple Aim. Okay? Everybody got that? Everybody got the instructions? Okay. Notes is on the bottom of your page on the slide. Better care for the individual, it says right on your slide, will be blue Post-it note right down here, then the yellow and the pink. Up here are the titles. So this is our individuals, this is our population, and this is the anything to lower per capita costs. Any questions? Just talk as a group. We want you to just come up, put these up. We'll read them out in about 5-10 minutes. How are we doing on solving the West Plan's problems? How are we doing? Everybody brought something up yet? Okay, let's try and bring some of your suggestions up in the next minute. And how many of you had class at 1 o'clock? Okay, we're going to try and wrap up to get to some other things, some information, okay? Microphone. Maggie wants it? Well, who's going to be, okay, you guys, Lindsay, do you have a microphone? You need to hear yourself. Well, we're just going to go up there. Yeah.
Can you turn this on? How do I turn it on?
Pick some to read.
Hello? Yeah, that's good. Wait, did that work? Can you hear me through the speaker? Okay. Oh, okay. Yeah, so.
Okay, everybody. So we're going to get right into this, sorry. Starting with better care for individuals. So let's see what we have here. Explaining things better and more time with the patient. I think we would all agree that would be better. Using the teach-back method. Good, some of you learned something in class. Better communication between providers and patients and improving patient education. Good. Medication therapy management. Looking specifically at lifestyle changes. More compassion. That's on there quite a bit. Using lay terms, that's a good one because this patient doesn't know what CHF is, and you heard the provider say that several times. Counseling on non-pharmacy options, good. And documenting details of each visit for future reference. Oh, that's a really good one. So somebody tell me something that could be implemented that either something that all patients should be getting or all providers should be trained on. Somebody raise your hand and put this into context for us.
Don't all jump to it.
We suggested developing a protocol, maybe specific to disease states that providers could use to educate patients and make sure that they don't miss anything that everyone should be aware of, and in lay terms that the patients will be able to understand.
Yeah, so like a checklist for appointments?
Yes.
Yeah, excellent. Anyone else? No? Okay. Something I thought of was offering educational sessions for providers on maybe counseling, and maybe it could be done by a pharmacist, and that would promote interprofessionalism, something like that. Anything else you want to say on this one? Okay. So moving on to the health of populations.
Okay, so the next IHI Triple Aim goal is to make better health for populations. So a few of the things that I noticed were people wrote interprofessional communication. They thought that was pretty important. A lot of focus on prevention and education about disease states to try to prevent them before you get to where Harlan is. Compassion, protocol, medical records, electronic medical records, a lot of social work I'm seeing. So does anyone have anything specific for Harlan's case that you think that you'd like to share with everyone that could improve better health for the total population? Anyone? Okay, cool.
To maybe like get a patient care home where there's a case manager for each, for a bunch of set of patients, and they take care of the patient and talking to their physicians and what they're doing at home. So like one person is in charge of a bunch of different patients, but they are in charge of that patient's care, and they can kind of collaborate with all the other health professions to make sure their care is complete.
Yep, that's a really good idea, because I think right now Harlan is in between the cardiologist, the pharmacist. Like, he doesn't really know who to go to get answers about everything. So that's a really good suggestion, to have one person manage his case and get kind of all the eggs in a basket. Okay, anyone have anything else real quick? Then we'll move on to the next IHI Triple Aim.
All right, so the next IHI Triple Aim is per capita cost decreasing, minimizing. So I saw a lot of generics. Generics are good. Generics are low cost. Another big theme in these that I saw was using MTM, which is medication therapy management, that pharmacists can perform to ensure that the drugs that a patient is on are appropriately dosed, and minimize the number of medications that are prescribed. And then there was a couple of them that were kind of a little bit mergy with better care for individuals too. So of course, like when you saw that Venn diagram, there's overlap. So there's a lot of overlap with all of these as well. So one of these could be better collaboration between physicians, which means less appointments and better medication therapy to decrease costs. So that's great. And then I think that was about, again, with the social worker too. Did anybody have any specific implementation strategies for the specific health system that they could do, other than just let's use generics for this individual patient, or bringing in a pharmacist? Anything else?
We talked specifically about the health of the patient and working towards incentivizing lifestyle changes. So the big issue there was that Harlan and his family unit could not afford these medications. So if the young physician kind of honed in more on his lifestyle and said, well, if you don't want to pay for this, if you could just walk more, then you could substitute that for taking medication. So I think looking at the whole person is also important instead of treating one symptom.
So what we talked about for lowering the per capita costs, we thought it was a good idea to have the doctor maybe come and either call the pharmacist before the patient came in, or call the different nurses and try and figure out what the best drug is, both like application-wise but also price-wise, because sure, there may be a lot of good generics out there, but if the doctor's always prescribing the brands, then they're just not going to get the right generic or generic in general.
Yeah, absolutely. So what I'm hearing is mostly we measures. Too, which is something that pharmacists can help with too.
So going a little bit broader and back to the IHI Triple Aim, it's all about doing these three things simultaneously. So by improving the health for the population, you'll reduce admissions in like chronic disease states, which will lower per capita costs and have better health care for individuals because they'll be healthy. So it's kind of doing all of these things at once. If you do one, then you can always, like Dr. Pagnucco said, you could always increase care, but will give better care, but that'll increase costs. So just all of these things are hand in hand, and it's tough to work towards them, but yeah.
Good job. All right. Any other questions before we just give you a little more information about IHI Open School? I know some people had to leave for class, so we'll hope they'll find us. Nora, you're going to do this.
I think I'm doing this.
Okay, so that's
How do I use the clicker? Just go over.
Yep, just your advances.
Okay, so why should you guys connect with the IHI? With IHI, I mean, our healthcare system, as we learned today, is pretty bad. So if you all want to help improve it in the future, you should definitely connect with IHI. And how can you continue to learn about quality improvement in healthcare? The Institute for Healthcare Improvement has open school courses. They're free online courses that you can take in areas like quality improvement, teamwork, leadership, patient safety, patient-centered care, and they're really awesome. So you could just go to ihi.org, and this walks you through. Nora, did you want to walk them? Okay. So if you're interested in signing up and you want to know how, we can give you these slides to log into ihi.org, make an account, it's all free, and take these online courses.
We also have these bookmarks. If you are interested, come and get one. They give you some more information about where to go to actually sign up for this too.
So I took these, and there's an app that I have. It's really cool. Okay, so I got involved in the open school because I was in the Clarion Competition last year, the IPSAT case competition. So I took the basic certificate. It took me about 20 hours, and it was really rewarding, and everything I learned in taking these classes were brought up in every single class I had after I took the classes. So it's all very relatable and really, really cool to just learn more about things that you aren't able to learn in school. So I'll hand you over to Nora to talk about the case competition.
Hi everyone. So I know a couple of you are here because of the Clarion competition. So as you've already seen in many of my emails sent to you, the only requirement is completing the basic certificate of the IHI Open School. So I just wanted to give you guys a little bit of deadlines for the competition. So the last day to send me or email me your IHI basic certificate is January 9th. It's a Friday, 2015. And we're going to have our kickoff day on the 24th. So the kickoff day is the day that you get to meet the members in your group. So basically it's 4 individuals in your group from different disciplines, but no more than 2 from the same program. And our local competition will be on March 7th. It's a Saturday And the winning team heads off to nationals on April 17th and 18th. So mark your calendars. So if you're interested, if you're still interested in the Clarion competition, just send me an email at ipsat@une.edu. And the last day to do that is December 12th, which is the last day of the semester. And that is to just let me know that you have interest in the competition and send me your IHI basic certificate January 9th. Oh.
Do you want to talk about like the timeline, get those in?
Oh,
quickly?
yes, okay. So teams are not gonna be made based on, who was the first one to sign up, but based on the day and time that you sent me your IHI basic certificate. So last year we had 6 teams. This year our goal is 8 teams. So what's gonna happen is if we don't have enough people for a team, the last ones to send me their basic certificate are gonna be cut out from being in a team, if that makes sense.
I know we're mainly pharmacy here today, but we've had a lot of interest in pharmacy. So we've got a bunch of people signed up. We may not be able to accommodate all of those people. So the first people to do these open school courses and turn in the certificate are the first people that get to compete in the competition. So even if you sign up and you get, you could get your certificate in on January 9th, the last day, we may not have a spot for you. So if you're really interested in participating, get those courses done early.
That being said, if you have friends in other programs, make them do it too with you so that everybody can compete, because this is a really awesome experience from somebody who's competed and then put it on. It's a really great experience and you don't want to miss out.
I know we have some osteopathic medicine students here too. This is open to you guys as well. Please, please.
Yes, John? It usually takes, well, for me, it took me about 15 hours, but it's about like, oh, for the actual competition or the base? Oh, I'm sorry. So, yeah.
Okay, so Minnesota, when we first did it the first year, gave us guidelines that students in the previous years have estimated anywhere from 20 hours to 100 hours. Now, this is over 6 weeks, so once you get assigned to your team, you have 6 weeks before the local competition. We have a variety of people. I'm looking at Lacey's participated in this. Who else has participated in the room? Just everybody up here? Okay. Again, this is part of why we wanted the IHI courses done, to give everybody that baseline information. So it's probably a lot less if you've done that now, because you understand a root cause, you understand quality improvement, things like that. But it can be significant. So the more people can get organized and get it done early, work towards practicing, the better it is. Okay?
And also after the local competition, you have an additional 4 weeks before national to sort of polish up before you go to nationals. So that could take another like 10 to 15 hours. Dependent.
Yeah, in that month period of time, Jeff Nevers and I have worked with teams in getting them polished up. And, the first year, gosh, we met like 2 nights a week, practicing and refining slides and getting things down. Last year, it was maybe once a week, maybe that way. But again, there's a lot of communication among your team members. If you think about this experience, and I'm sorry to jump in because I wanted it to be theirs, but this is really like a simulation center. To actually, what we chose to do when we started doing this was we randomized the students to teams. Because we've had such strong pharmacy, there tends to be 2 pharmacy students per team, when that may turn out that way again. But the other professions get randomized because you don't know who you're working with. You're going to take a job, you're going to be practicing somewhere. You don't know who your social worker is. You don't know who your PT is. And you have to be able to utilize all the skills that you've learned in your lifetime and in your programs about working respectfully, communicating well, and centered around the patient. And so, I think people who've done it and from the organizing side can attest to the fact that you really sometimes have to have some of those struggles to just mimic what it's going to be like when you get out there. Okay?
Any more questions?
Okay, so I'm Lindsay Robusto, if you don't know me. I just wanted to talk about an opportunity other than the competition that is available to students, and that's what we call the SQUALA, or the Student Quality Leadership Academy. It's something that the IHI Open School puts on every year in the summer. So first you apply, and any student can apply. Oh yes, it's free. Okay, so here's the thing. So what you do is you apply to the IHI with a short little blurb of what you would get out of this experience, and I'll tell you in a second what I got out of it. And it's any student that's currently enrolled in any healthcare profession, or actually it's not even just students, residents, professionals, anybody who is enrolled in the open school courses can apply for this. And they give you a scholarship to go down to Cambridge, Mass, and spend 2 days working with other healthcare professionals, future professionals, and developing your leadership skills in the context of healthcare improvement. So the other thing too is, like, they give you a hotel room, they give you food. It's amazing. It's a lot of fun. But so what I went to it for was because I had this very big interest in furthering my leadership skills, but also understanding how I can play a role in quality improvement. So, so again, this is how you apply. Sorry, so can't even remember my slides. Her slides. So when you apply in the spring. They don't really even open it up until like May-ish, April, May. And when you apply, you don't need a letter of recommendation or anything. You just go, you apply, and you write them like 400, 800 words of what you want to do there. And so what I did was I wanted to learn how I could bring the Institute's goals in terms of healthcare improvement and bring it back to our students here and learn what I can do to inspire more people to be more active in the quality improvement and healthcare improvement realm. And when we went, we ended up working with interprofessional teams. We met people from all over the country and even like the globe. There was somebody from like Chile. Yeah, it was really cool. And we just talked about how we can all be change agents. And what a change agent is somebody who is a leader in healthcare improvement that wants to inspire others to be active in healthcare improvement and actually do something about the quality of the healthcare that we have today. So we developed our skills with that. We did some interesting team building activities with like making little race cars that go as fast as possible, and it was just a lot of fun. So the people who went last year were myself, Maggie Jones over here, Morgan too, and then Chris Ortiz and Ian Imbert. So it was 5 of us that were accepted from, I think, 11 applicants, so from UNE at least. So that's 4 of us. Chris decided to bail. So yeah, you'll learn specific skills relating to leading change, communicating effectively, leadership challenging. We made a lot of friends. We went out in Boston and had a good old time. You get to develop a personal narrative, which what that is basically an illustration of why you got into healthcare and why you feel strongly about improving healthcare, and it's supposed to inspire others to also feel strongly, which I can tell you mine if you want to come to me after this. So yeah, and that's a lot of us, and what we're holding, the pieces of paper, were our, what were they called? It was like a commitment to be change agents. So It's this big initiative in the IHI community where we all sign up to commit to change the way our healthcare system is. So, and Morgan and I are in the front. It's fun. So that's it. I don't have any more closing remarks. If you have any questions about any of this, please feel free to come up and talk to us. I have some more instructions on how to sign up for the IHI courses up here, as well as little bookmarks again. And if you're interested in the case competition, do also come up or email the ipset@une.edu. And we look forward to talking to you guys and working with you in the future. Thanks for coming, guys.